I want to respond to some things that Mark said. First of all, I think it's easy to say that patients have different demands for privacy at different times. I've talked to people who, privacy lawyers, who take their kid to an ER and they say, I'll sign anything, I'll agree to anything, just treat my kid. And in other contexts, it's not always, people are not always so liberal. And some people see psychiatrists. A lot of people think that's sensitive treatment and think it deserves special protection. At the same time, if you're like me, you know people who've seen psychiatrists. Some of them talk about it. Some of them talk about it all the time. It's not that sensitive to them. On the other hand, I don't know anyone who's ever seen a proctologist. Nobody ever talks about that. So, you know, what's sensitive? It varies. And in an ER, things are different. Also, I think in terms of the HIPAA rule, there are a lot of problems with the HIPAA rule. One of the things that it's gotten right for the most part is a flexibility in the treatment relationship between the doctor and the patient. So there's no requirement in HIPAA that patients have private rooms. There's no requirement in an ER that you can't say something to another, to a patient or to another clinician that might be overheard. It's not that firm. In other contexts, maybe, but there's a lot of flexibility there. There's a lot of flexibility in terms of sharing information between physicians and families. You know, somebody comes in, I'm taking care of, it may be my aunt, it may be my neighbor. The doctor has a lot of discretion to decide what information to share without a lot of paperwork. There's a lot of professional judgment called for under the law, which is exactly the right answer. There's nothing better than a smart clinician paying attention to what the patient wants, what the situation needs. And I think the clinicians, to a large part, are not the problem in the healthcare system. It's everybody else more likely to cause trouble. Another area, Kim talked about the minimum necessary rule. It says, okay, you can only share the minimum necessary information for whatever the purpose is. It doesn't apply to treatment. So doctors can share information, they get anything they want. It doesn't apply to them because it would be too much of an interference with what they're doing. So I'm not saying that the law is perfect by any means, but there's been a lot of accommodation, and the one area where I can really say that HHS did well, almost without exception, is in this area of emergency treatment and family relationships, where physicians are given a lot of discretion to do what they need to do.
Mark, you and your hand up there.
I want to respond to Bob, and then I have a couple of questions for Kim. So I'm happy to hear that the law permits all that stuff, and maybe the problem is that the average worker's understanding of the law, well, that's the reality. And I'll give you. I like examples. So somebody comes to the emergency department, they have chest pain, they have an abnormal electrocardiogram. When you see somebody with an abnormal electrocardiogram, the first question you have to ask is that abnormality known to be old? If it's been there a long time, it puts them in a different category. If they had a normal cardiogram 3 weeks ago and they have an abnormal cardiogram now, that indicates it's a acute cardiac event, and it requires a different treatment pathway. This patient was sitting in, he said, I was at Howard Hospital three weeks ago. Well, 20 years ago, what would I do? I pick up the phone, I call Howard Hospital, I get the doc in the ER, hey, this is Mark Smith, fax me over the EKG. Done. He's fine, he'd send it. Now, for whatever reason, maybe their incorrect interpretation, but that's the reality out there. I got to get the signature, I got to fax this, it's 20 minutes, 30 minutes, time is muscle in the heart. So that's the, I think that, and that was the point I was making before, that this is so pervasive that the HIPAA police are going to get you, that people are afraid of doing things that they think may be transgressing and consequently hurting patients. Second point I'd like to ask Kim. I mean, it was a very eloquent and reasonable navigation of trying to protect people's privacy. But I would, and ensuring the integrity of the data. I actually think the problem with dirtiness of data is an extreme problem, and the best way of finding out that data is dirty is making it public and exposing it, as opposed to hiding it under rocks and making it difficult to get to. But I am curious from and my three colleagues hopefully would know this. You know, what have been the major breaches of privacy that have occurred in the last 10 years, and what is the cumulative amount of harm that's occurred from those breaches. And let's balance that from what is the cumulative harm that's occurred from keeping information hidden and not making it available to clinicians, or make it more difficult for them to get to it with consequent adverse outcome to patients. I can measure that one pretty well.
Can I answer that? I want to tell a story. This was an investigation done in Canada, but all the players, many of them were Americans. You talk about calling another ER and you're telling it to give you information, and they just do it in the old days. Well, there was a detective company in Canada that made a living. They hired nurses and they called ERs and they said, can you fax over records? And they were buying records, they were stealing records, they were getting records under false pretenses. This was an industry. The entire insurance industry in Canada came before this investigatory commission there and pleaded guilty to stealing records using these techniques.
And what did they do with the records?
What did they do? They used them against the patients in litigation. That was one of the things. They were used by employers. Anytime you wanted a record on somebody, you go out, you hire a detective company, you get records that you weren't entitled to have otherwise, and patients were harmed by that. So there are plenty of examples of that going on.
Well, I know we can find examples. I want to quantitate the amount of harm. I mean, how many patients, how many insurance companies? I mean, let's this is relative harm in terms of numbers of people and severity. Are people dying because of it? Because somebody breached a record? How many records were breached? I mean, I appreciate the example, but I think that we've never, I'd like to see both sides out on the table.
There was an investigation done in this country, in Denver, in 1976, that found the same thing I just reported. It was pervasive. It's probably pervasive now. The only reason we don't know is no one's gone out and looked at it. But the two major investigations done in North America over the past 30 years found the exact same thing.
Well, Bob, I would say to you that that doesn't even come close.
Whenever you compare something to life and death, you're never going to.
Well, that's right.
So
Well, that's exactly right, Tim.
Having said, so we're not, nobody's going to win here because we're talking about death versus other, right? So I think the key is that you're talking about what might happen to one individual here, one individual there, another individual here. When you have a major security breach, or let's say some of the things that have gone on recently, whether it's out at Stanford or the VA or Cedars-Sinai, or just the list goes on and on for the breaches that have occurred just in the last 2 years or 6 months, let alone 10 years. But you look at that and you're talking about tens of thousands, if not potentially hundreds of thousands of records, not just one or two people that might be affected. And I'm not saying that those one or two people who could possibly be impacted lives are any less valuable than, but if you're talking about, but if you, right, so, and I know, but if we're talking about what we have to do in order to try to avoid the hundreds of thousands, there's no reason why you shouldn't be getting, as a clinician, shouldn't be getting the information you need to treat someone. There's no excuse for that. That is not part of the law. That's not part of how it's supposed to be implemented. If you're not getting that information, it may not even be a privacy or security issue. It may be because your electronic health record has a lot of crap in it. And we implement systems, and I see what those progress notes look like, and quite frankly, I know that half of it is just for billing purposes. It's not because it's helping the patient get better care, and you know it as a doctor. It's there so that you have good documentation so that your claim doesn't get denied. That's what these systems are being built for. They're not being built necessarily to even make it easier. I mean, a clinician used to be able to pick up a paper chart and flip exactly to the place where they expected to see something. And today in the electronic world, when you have a screen that is really complicated and you've got multiple tabs across, the top, and you've got different places that you can go for the same information, I think that's a bigger problem than somebody putting a security setting in place that they shouldn't have put in place, or saying to you from the ER they can't give you the information.
All right, let's let Sumit get a word in. Let Mark respond to that, because I think he probably wants to. But Sumit, you go.
Well, I think it's more to your point, just with regard to quantification. You're more looking at you can't really quantify the degree of effect a breach has on an individual. I mean, yes, we could go down that path that there's a whole underground industry worth billions of dollars that deals with cash on records that are obtained that may not have to do anything with the electronic health record. A lot of times it's the identifiers you get out of that health record, and maybe for 10% of the population that has the psychological problems or the HIV issues or something that can hurt their reputation, people are there to exploit it. Now, does that happen if you have a breach and 1 million people's record gets out, and will all 1 million people have that problem? Probably not. The issue comes in is for the 10 people that have had that issue occur, where their life got messed up because their records got released, that for them becomes a very real effect, and in some cases could be detrimental to how they lead the rest of their life. Now, that's one side. From a security standpoint, to be able to care for that patient is paramount. I mean, that's why they come to the hospital, and nobody comes to the hospital just to hang out. They always come because they have problems, they're in a weird state, they're vulnerable, and a lot of times their expectation of security privacy is less in a clinical setting when they're the patient as compared to them walking in the bank and asking the teller to give them money in, or receive money for that matter. So there's two sides of the equation coming in. A lot of the balance, which I agree with Kim, is the systems or the processes that we're going towards. And we need to make sure that we get the processes in place that have checks and balances with regard to clinical processes and billing processes and the ethics behind it. Because a lot of times IT becomes blamed for all of that stuff when we're just the people that are providing those tools. The framework needs to be built out properly.
Let me ask Mark to finish off this particular segment, responding to whatever you want to respond to. And also, I have a question specifically respond to Kim's comment about a lot is just for billing, because I know Mark's developed a system.
Well, Kim's totally right, and we can talk about how terrible electronic health records are. But let me just say a couple of things. First of all, I don't deny that there could be significant harm coming from breaches of security and violations of privacy. All I'm saying is, let's look at the harm there, and let's look at the harm that comes from preventing information from being sent to the list, even if it was not the intent of HIPAA to do it, and try to get a sense of scale. No one's condoning somebody breaking the law and breaking into somebody's medical records, and it may be, Bob and I were talking before, easier to do that in this era where they're all kind of in digital form than their individual piece of paper sticking up on somebody's wall. But I will say that I think that everything you do tends to have unintended consequences, and you can design your processes and your security policies in a smart way and see what kind of effect it has on the clinician. I'll give you just two quick examples. In the old days, before electronic health records, when we had whiteboards, you've seen in the emergency departments people's name, and we used to have the name and we had the complaint up there. So Harris, leg pain. Jones, shortness of breath. And that was an edict came down from the Joint Commission saying you can't do that. You can't have those two identifiers there. That is a violation of patient privacy. Take it down. Well, we had to take it down. We were blind because we had a mental map of the emergency department, and we identified, we don't know the person's name. Oh, it's the person in 13 with a fractured leg. And so we were put at much higher risks for misidentifying patients and for making mistakes. We put in that example one. Example two, in the good way, is if you've got you can cause a log out every 10 minutes and have to go put your password in. That is so annoying, and especially when clinicians have to move very fast. We had for a while just a badge ID, and that small change in form factor made a huge difference in how comfortable and easy we felt about accessing the information. So the technologies that are chosen to create the more secure environment, it's very important to see how they affect the clinicians' ability.
Totally agree with that.
I promised Bob Gelman he'd get no more than 1 minute to respond. Nobody's going anywhere. Most people aren't going anywhere, which is the good news. But I want to give the audience, especially those who have to leave and can't stay for part two, to get a chance to leave. So Bob has 1 minute. Then I'm going to put my panelists on notice to think about this question. Bob will come back to you at the end of this, which is, if you were God and you could change one thing or do one thing, what would it be in 30 seconds? We're going to do that at the end before we break for lunch. But Bob, you have your 1 minute here.
I mean, I recognize the points you're making, Mark, about the trade-offs that are involved, and it's perfectly fair. HIPAA says any covered entity can disclose any record to any provider for the treatment of any patient, any patient. I don't know how you could write a more liberal rule than that.
That's great.
Now-
Unfortunately, nobody knows that, but that's
No,
great.
absolutely. No, it's not, there's requirements for training. You've got lawyers in the hospitals who are screwing this up. The lawyers don't understand private, I'm a lawyer. The lawyers don't understand privacy, and they require all kinds of crap that is not necessary.
One might say there's an industry.
But
that-
the point is, you can't go home again. If I came along and said, we're going to repeal the entire HIPAA rule, you know what would happen? The lawyers would take over the world and everything would be worse. Once you start paying attention to privacy in any kind of organized way, you got to have rules. And if you don't get rules coming in from, HHS or wherever they come from, you're going to get local rules and it's going to be worse. So, 30 years ago, when no one paid attention to privacy, you could do all of that, and there were lots of abuses and lots of problems, and there are probably still lots of those abuses, notwithstanding all of this. But we do have some rules, and they have made some things better.
Okay, Kim, if you were God, 30 seconds.
This has to be about privacy and security, right? Okay. Gosh, that's a tough question. So, I guess if I were God and really had control over anything in all of this, I think it would be that we would have less incentive to actually abuse any of these systems to begin with. I mean, I think that's a big piece of it, as Sumit alluded to. I mean, when you're talking about a lot of the breaches that occur, it's because there's money involved. And, there are the snooping cases that we get. But if it weren't so lucrative to actually go after the information, the rich information that's in these medical records, we wouldn't be dealing with a lot of the issues that we are.
Okay, Mark, you were God.
I'd probably try to flip the paradigm to make it patient-centric and have the personal health record where the patient owns all of his or her data with total control over who gets what and able to parcel whatever segments that they wanted out and make those decisions away from the provider-centric model for how data is kept.
Sumit?
I'd fast forward to the Star Trek world where money disappears, and you become where everybody works to better themselves and to better everybody else. I mean, as idealistic as that world sounds, it really does apply here. I mean, you're trying to balance, as the title says of this panel, you're trying to balance a very human aspect with technology that has a yes or no function in a gray area. So I really think I agree with Kim on, if you take the incentives out, it can definitely help. But getting it from a patient-centric point of view, it can make your vision more clear as to what your eventual goal is.
Bob, you were God.
If I were God, I think I would veto Mark's suggestion of patient ownership of records, which is really a total rat's nest that leads to terrible policies all over the place. It's really hard to come up with something to say from the God perspective, if you will, because there are so many trade-offs that come along that you just can't, there's no single bullet there. You just have to make a series of decisions back and forth about how to deal with things. I guess if I had to pick something, it would actually go to Mark's other point, that I wish we could get people to actually follow the rules and know what they are better. And my wife, I get the same complaint from my wife, who can't get records to treat the patient when it's perfectly lawful for people to do so. And if those problems would go away, and they will slowly over time, it's gotten better over the years since HIPAA came along, then that would solve some of the problems.
Okay, we're going to all be here for another hour or so and have lunch with everybody together. But for those who have to leave, I want to give people, for everybody, give people a chance to ask questions of this panel right now before a break. So this is first shot at questions. Who wants to go first?
I have a question.
Ross.
I can look at this from an academic standpoint and what we teach in security, and that is that the goal of security is to make the right information available to the right person at the right time. And from that simple viewpoint, what I'm hearing, what I know from the real world is being misapplied. And one of the big problems is that we put that goal into a framework of what we call the CIA triad: confidentiality, integrity, and availability. Kim mentioned the integrity issue, and that's important. We need to look at the last one, though, availability. It turns out that probably the easiest thing to do is to accomplish confidentiality, because we can just close the doors and then just kind of open whatever windows or whatever to allow certain people in, but that ignores the overall goal of security. My question is, I'd like to kind of flip it around in terms of the balance between confidentiality, integrity, and availability is really for management to balance those, or in this case, probably regulators and what have you. But if that balance could be accomplished, my question is, do you see some significant benefits to having electronic health records as opposed to the old system of paper files? Anybody?
I see tremendous benefit just from a standpoint of being in this industry for the last 10 years and seeing their adoption come up. I mean, I've seen them across the board. Now, how much of those benefits are utilized depends on the culture of the organization and on the generational, for lack of a better word, differences between the clinical staff that are utilizing them. I mean, even the practice of medicine essentially remains the same, but how we do it either becomes better, or we do more things and make it more effective. Now, to achieve the balance of moving forward in innovation and making better, bigger things happen more quickly and more safely, that takes an effect on that balance of integrity and availability. To your point, in healthcare, it's really hard to manage that, because like Dr. Smith said, availability, if you don't have that information, if it takes you 5 more minutes to read that PACS image in the ER for somebody that's coding, that could have a real effect in their life. Well, your God, you grant your wish and you get availability and you have that information right there. But then to Kim's point, if it's not correct, how do you deal
have to
with
know
it?
it's.
I mean, my experience with the
You
paper
gotta trust
system,
it.
my experience with the paper system, though, is that availability is extremely poor in a lot of situations. in
Yeah,
terms of-
charts go missing, they're in someone's trunk, I mean, you never knew where
And
they were.
the other problem is you get value to the patient, to the system out of data if you can repurpose that same atom of data for multiple different ways. Care of the individual patient, making observations about populations of patients, guiding workflow, putting up dashboards, doing reminders, and serving as the basis for decision support that perhaps improves care. So there's no question in my mind that this has the potential for substantially improving the care, preventive care, as well as of the population. I have one comment about the confidentiality of the information, which is an interesting one, because I think we're all used to, oh, let's go look at the, we want to see something, let's look it up on the screen on the patient, and that's sort of the model. And there's an intentionality there and a singularity of focus that is not the only way, and may not be the best way of getting information. Because you sort of want information to be available, I said, ambiently and at sort of multiple different distances and or altitudes or zooms. And it may well be that you want information posted, around you as you're walking around. That may be a safer environment. And I think that's there's a clear trade-off there between confidentiality and being able to pick something up faster because it's being pushed on you, and it's being pushed on you in a way that you don't even have to go check your mobile device, but you're walking over there and I see it out of the corner of my eye. So I think that's an open question about how information should be displayed to maximize care, and where does the trade-off on confidentiality and privacy
It's
there?
who we trust and what we trust them with.
Exactly, yeah.
I think there's definitely value and benefits that have come out of electronic health records, and that's a whole nother topic. And, you know, whether that's financial or quality of care, that's all debatable, and there aren't very many good studies. But one example, since we like examples, that where I think it would be hard to argue is in e-prescribing. I mean, look at, you know, right now, when you've got standards in place, data standards, and you've got things where every single certified system out there can do e-prescribing, and they're all sending to most major retail pharmacies as well as all the insurers. I mean, I think you really see there, you know, something that's a simple kind of transaction, but where that information truly benefits quality of the care and, you know, what interactions there could be, and even, you know, fraud detection, all kinds of other things. So that's just one example.
Can I respond just quickly? I think there are a lot of problems and costs with electronic health records, but I don't think there's any question that there are benefits as well. I mean, the healthcare industry still uses fax machines. And who uses fax machines anywhere anymore? You
Use
know?
pagers too.
Yeah.
Yeah.
Come on. I mean, you know, you got to move along here in some way, and you got to deal with all the complications and all the trade-offs.
I mean, I'm a technology optimist from the standpoint of, I mean, I really believe that we have the tools and techniques to make it happen, to make it work. It's really that balance that.
But as Bob said, healthcare is lagging behind other industries by 15 or 20 years,
Sure.
which makes it a great space for innovation and moving forth, because there's so much opportunity.